All right, we'll talk about antiarrhythmic medications. Before we talk about antiarrhythmic medications, we need to look at what the action potential of the myocardium looks like. We have two general different types of action potential you want to care about or that we are concerned about. One is the action potential of the myocardium, the heart muscles, the cardiac myocytes. The second is the action potential of the SA node and the AV nodal, both literally the same thing. And it's important that you recognize exactly what is going on with these different action potentials so that you can understand how these medications affect them. We are talking about antiarrhythmics. Antiarrhythmics are medications that are anti-arrhythmia, that abort arrhythmias, right? And restore rhythm to the heart. When we have a cardiac myocyte action potential like this, you may recognize this to be phase 4, phase 0, phase 1, phase 2, phase 3, and then back to phase 4. You would remember that phase 4 is the resting membrane potential. Phase 0 is the depolarization phase. Phase 2 was the plateau. We had that sharp dip in phase 1, and we'll see why that was there, right? And then we have the rapid repolarization. Phase 3. So you want to remember these different phases. More importantly, we want to know why each of these phases occur and what is responsible for them. So we are going to have a little line here. Below this line is going to be our ICF, intracellular fluid, and above this line will be ECF. What it means is if I draw an arrow going this way, it means efflux. If I draw an arrow coming this way, it means influx. So you have something coming into the cell, efflux, you have something ejecting the cell, leaving the cell. Right, let's talk about phase 4. Phase 4 is resting membrane potential. All right, phase 4 is resting membrane potential. The question becomes, what is responsible for the resting membrane potential? Or what is going on in phase 4? Here, we have sodium ion channels and calcium channels closed. You want to remember that. In phase 4, we have sodium and calcium channels closed. We have leaky potassium channels open. We have leaky potassium channels open. And you want to remember that these potassium channels are actually rectifier channels. And what happens here? We have efflux of potassium from the cell. We have efflux of potassium from the cell. That's what's going on in phase 4. And the efflux of potassium from the cell maintains this resting membrane potential at minus 90 millivolts. It maintains the resting membrane potential at minus 90 millivolts. And then we move on to phase 0. We move on to phase 0. Phase 0 is the depolarization phase. Phase 0 is the depolarization phase. Phase 0 is the result of rapid sodium influx. It's the result of rapid sodium influx into the cell. Okay, so what happens in phase 0 is that you have a lot of sodium channels open, and these are fast sodium channels. Fast sodium channels. And sodium begins to come into the cell from the extracellular fluid. Sodium begins to come into the cell from the extracellular fluid. You want to know that those channels are fast sodium channels. Remember that sodium comes into the cell in large amounts, very large amounts, so a lot of sodium. That's why you see this upstroke very sharp, right? You have this upstroke very sharp. And we are going to see how antiarrhythmics, sodium channel blockers are going to affect this phase 0. So when we give each of the characteristics of these aspects, you think of the medication that is going to affect each of these slopes on this graph. So if we have this depolarization phase under the influence of sodium influx, you can imagine what will happen to this line if I give someone a sodium channel blocker. We block all those sodium channels, and electrical potential, action potential does not move as quickly. So you expect a dip. This slope is no more as steep when we block those sodium channels. And we'll see that when we talk about type 1 antiarrhythmics. The next phase we are going to look at is phase 2. You see that sharp dip. If this upward stroke is depolarization, a downward stroke is repolarization. A downward slope is repolarization. So we'll go to phase 1. What's going on in phase 1? Repolarization. Repolarization, downward strokes, is always as a result of the activity of potassium. Repolarization is always as a result of the activity of potassium. So phase 1 is as a result of transient opening of potassium channels. Transient opening of potassium channels. And when they open, what happens? There's potassium efflux. You may remember from your physiology that potassium is inside the cell, sodium is outside the cell, and they tend to move in opposite direction. You remember 2:3 ratio and all of those things that you did. So that sharp dip is as a result of an influx, or efflux rather, of potassium. The potassium is leaving the cell, an efflux of potassium. The next phase we'll talk about is the plateau. You see phase 2 right here, you see the dip. Actually, this is supposed to be more stable like that, almost a flat kind of line. And phase 2 is as a result of calcium influx. So picture this going on. I told you that phase 1, the dip at phase 1 is due to what? Potassium channels. Potassium channels are coming into the cell in this manner. And then when you get to phase 2, calcium channels open, and so potassium is coming in, and calcium channels open, and calcium starts leaving. You have positive ion coming in, positive ion leaving the cell, and then there is an electrical balance that forms between potassium and calcium. That is what happens in phase 2, an electrical balance between potassium and calcium. And that's what creates that flat line that we see, that plateauing of the action potential. So phase 2 is as a result of calcium influx. Calcium influx. And you want to remember that this calcium is coming in via the L-type calcium channels. It's coming in via L-type calcium channels. And that there is electrical balance with potassium efflux that produces the plateau phase. There's electrical balance with potassium efflux that produces the plateau phase. We just mentioned the L-type calcium channels. Do you remember the T-type calcium channels? We have T-type calcium channels, and there's one specific area where you need to remember them, and in particular medication that inhibits T-type calcium channels. I hope you're thinking of ethosuximide. You remember that ethosuximide inhibits thalamic T-type calcium channels. inhibits thalamic T-type calcium channels. And we use this to treat what? Absence seizures. We use this to treat absence seizures. You want to absolutely remember that. That is a question that could be on your exam. All right, so that is T-type calcium channels. We have different types of calcium channels. That's all we want you to know. L-type calcium channels are the ones we are talking about here specifically. The next phase is going to be phase 3. Phase 3 of action potential. Phase 3, you see, it's a downward slope. It's a downward slope. So what's this? It's as a result of potassium activity. And this is the rapid repolarization stage. Sodium caused a depolarization. Potassium is causing a repolarization and is going to bring the cell back to resting membrane potential. So phase 3 is where the calcium channels, remember calcium channels and potassium channels, we are forming a balance. There was calcium influx, potassium efflux, creating this balance in electrical potential or action potential that produced the plateau. So in phase 3, now we have those calcium channels closed and only the potassium channels open. So the balance is distorted and we continue with a downward trend, right? So calcium channels in phase 3 close. Calcium channels close, right? Or become inactivated. I think sometimes you're going to hear them say the channels were inactivated. Remember, every time we say closed or open is the same as inactivated or active, depending on what you're looking at. When these calcium channels close, the delayed rectifier potassium channels remain open. That's the balance we talked about that is distorted. And then there is return to resting membrane potential at what? Minus 90 millivolts. You don't have to memorize any of these numbers. It's important that you have this chart in mind. You have that sodium is responsible. Sodium is responsible for the depolarization. Potassium is leaky potassium rectifier channels are responsible for phase 4. Calcium is responsible for the plateau. Potassium is responsible for phase 1. Potassium is responsible for phase 3. If you remember these, you should be good to go. The one other thing you may need to know is that this distance is the absolute refractory period. The absolute refractory period. And what the absolute refractory period is a time during which another action potential cannot be elicited. The absolute refractory period is a time or a period during which another action potential, a second action potential, cannot be elicited. The full length of this graph from the start to the finish, from the start to the finish is the ERP. Okay, the ERP, effective refractory period. Effective refractory period. I hope I remember that correctly. Is that effective refractory period? I think it is the effective refractory period. All right, now we'll move on to the classes of antiarrhythmics. First, we have class 1 antiarrhythmics, which are sodium channel blockers. Then we'll look at class 2 antiarrhythmics, which are beta blockers. We'll talk about class 3 antiarrhythmics, which are potassium channel blockers. And then we'll talk about class 4 antiarrhythmics, which are calcium channel blockers. And we'll see a few other medications after that. Beginning with class 1. Class 1 drugs, like we said, are sodium channel blockers. What you want to remember is that there are different medications under class 1 blocking different types of sodium channels. The sodium channels exist in 3 main states. I will look at what they are right away. They exist in 3 main states. We have the active state. This is an M actually. The active state of the sodium channel is when the sodium channel is completely open. Completely open. We have an M gate, it's like 2 gates, and a H gate. We have an M gate and a H gate. The active phase is when both the M gate and the H gate are open, and sodium is free to move across that channel. The H gate, though, is going to slowly close. Okay, this first diagram illustrates the active state of the sodium channel. Oh, we still have some of our notes right here. We need to take out these guys. The active state of the sodium channel, and you want to remember that. All right, that's the first type of sodium channel, the active sodium channel. Active. The second type of sodium channel we'll consider is the inactive sodium channel. The inactive sodium channel. The inactive sodium channel has its M gate open. M gate is open, but the H gate is closed. The H gate is closed, meaning that even if sodium comes through, there's a barrier right there. This is the inactive sodium channel. And this channel is actually in refractory phase. It's said to be in refractory phase. The third type of sodium channel that we have is the resting channel. The third type of sodium channel is the resting channel. With the resting channel, the M gate itself is closed, but the H gate is open. The M gate is closed, but the H gate is open. This is the resting channel. The resting channel. And different antiarrhythmic medications work on these channels differently. And they all bind with different levels of affinity. They all bind the channel with different level of affinity. Class 1A medications work on the active sodium channels. Class 1B medications, and we'll see these classes in a bit, work on the inactive sodium channels, and class 1C medications work on the resting channels. Class 1A works on the active channels. Class 1B work on the refractory channels or inactive channels. Class 1C work on the resting channels. You want to remember that class 1C medications bind with the highest affinity. They bind with the highest or strongest affinity. You want to remember that. You also want to remember that at about minus 50 millivolts, I think it's the M gate. The M gate closes. While at about minus 85 millivolts, that's close to resting membrane potential, the H gate opens. Nothing too important there, just hear it and try to remember it, and that will be great. All right, let's go to the actual thing we need to bear in mind. We are going to compare the class 1A antiarrhythmic medications side by side. We'll compare the class 1 antiarrhythmic medications side by side. Right? We'll compare them side by side. All right, I think I'll need a little straighter line here. Great. So here we have class 1A, 1B, and 1C. And we'll see how each of them affects different parts of the heart or different types of sodium channels and what their effects are. I'll give you a simple way of remembering this. So a number of students ask me, how do I know which medication is going to be used to treat which condition? Or, you know, those type of questions. When you go to do UWorld questions many times, it looks like students don't recognize how exactly to figure out the answers. Here's something simple I came up with. And you don't have to take it as law or too standard, but it's just a general idea that will help you recall this information easily. Class 1A works on supposed normal heart. Normal heart. It's a normal heart. Why are we giving medication? Normal heart means it does not have any injuries, like physical injuries to it. It may have a congenital defect. There may be a reentrant pathway, but it's a heart that is not necrotic or damaged in any way. Class 1B works on damaged heart. This is the heart of somebody with MI or somebody that has taken a lot of drugs and the drugs have damaged the tissue, like digoxin. We'll talk about that in a moment. And class 1C is used for dying heart. Oftentimes, they're used as last resort, actually, when a lot of other medications cannot seem to help. Now, what is the effect of class 1A antiarrhythmic medications on the heart? If you remember, we saw our action potential, myocardial action potential graph prior to this time. We had drawn this. I hope you've seen that lecture. We saw that graph for our myocardial action potential. And we had said that phase 0, which is right here, is due to sodium, what do we call it? Influx into the cell, right? Phase 0 here was due to sodium influx into the cell during depolarization. Now, when you give sodium channel blockers, what do you expect to happen to the slope of phase 0? You reduce the steepness of that slope, and you're going to have something that looks like this. You have something that looks like this. What you want to know as well is that class 1A antiarrhythmics also have potassium blocking effect. They have potassium channel blocking effect. What does that mean? That means that this phase 3 potassium depolarization is also going to lose its steepness. It's going to become less steep. It's also going to become less steep. So when we draw this graph, we are going to have something like this. The new graph would look like this. Block sodium channels, we have our plateau over there, and then block potassium channels as well. That is what the new graph is going to look like. We block sodium channels, and it also has some inhibition of potassium channel. So remember this, class 1A medications also blocks potassium channels. It also blocks potassium channels. This could help you understand why you should have this outward movement over here. Overall, when you think of this, you have actually increased the action potential duration. You've increased the length of time it took This is the absolute refractory period. But you've increased the length of time it took for the action potential to occur. So class 1A medications will increase action potential duration. That is one. They will also increase the effective refractory period. So if we decided to find what the effective refractory period is over here, they would also increase the effective refractory period. You want to absolutely remember that. The next thing, of course, you have to know are the medications in class 1A. The medications in class 1A. We have disopyramide. We have procainamide. And we have quinidine. Disopyramide, procainamide, and quinidine. Those are the medications under class 1A. There are mnemonics you can use to learn them. I don't know if you would find that useful. All right, so bear that in mind. The second thing you need to remember are the side effects of class 1A medications. The side effects of class 1A medications. Now, the good thing here is that each of them actually have individual side effects, and then they have a class effect. Disopyramide, for example, would cause heart failure. Disopyramide will cause heart failure. Procainamide will cause SLE-like symptoms, like drug-induced SLE. Do you remember that when people have drug-induced SLE, we have a specific antibodies that we could find in those patients, antihistone antibodies. You remember antihistone antibodies for drug-induced SLE. Quinidine, on the other hand, would cause synchronism. These patients will usually present with tinnitus, hearing loss. Tinnitus and hearing loss is basically the same thing. They may have diarrhea, nausea, vomiting, whatever, right? You want to remember that for quinidine. You want to remember that as a class effect, these medications can cause prolonged QT interval. And if you prolong the QT interval, you increase the risk of developing torsades de pointes. You want to remember that. The risk of developing torsades de pointes. There are additional things you can learn or recall about class 1A antiarrhythmic medications. You can remember that they have tendency to cause thrombocytopenia. For example, they may cause thrombocytopenia, but that's not big on the exam, right? That's not very big on the exam. And then the next thing is their use. What do we use them for? Again, we said you can use them for normal heart. So if we are talking about normal heart, when we say normal heart, what comes to mind? Maybe there is just increased heart rate. There is just increased heart rate, right? Like someone with supraventricular tachycardias. We use them for supraventricular tachycardias, SVTs. We also use them for regular ventricular tachycardias. I think we also use procainamide to treat congenital defects, such as you see in Wolff-Parkinson-White syndrome. So I think procainamide is also used in treatment of Wolff-Parkinson-White syndrome. You want to remember those. The second class of medication we are going to look at are class 1B medications. We want to see how class 1B drugs actually affect action potential. See how class 1B medications actually affect action potential. Hurry, hurry, hurry. Again, there are sodium channel blockers. So what do you expect to see? You expect to see a decrease in the slope of phase 0. But class 1B medications do not have sodium channel blocking effect, or potassium channel rather. They don't have potassium channel blocking effect like class 1A. So we have a graph that would look something like this. Notice what's going on here. The action potential duration and effective refractory period are reduced. So class 1B drugs, this is shorter than the original. So class 1B drugs decrease the action potential duration and decrease the effective refractory period. You want to remember that the effective refractory period and the action potential duration are decreased. Basically, if you notice what's going on here, it's like repolarization is occurring much earlier. Repolarization is occurring earlier. So we could say that class 1A medications accelerate repolarization. Class 1A medication accelerate repolarization. They do not block potassium channels. They do not block potassium channels. What medications do we have under class 1A? We have lidocaine and mexiletine. Lidocaine and mexiletine. And they have a class effect in terms of their side effects. They both can cause neural and toxic and cardiotoxicity. They can both cause neurotoxicity and cardiotoxicity, right? Oftentimes it's going to be cardiovascular depression and maybe CNS depression or elevation, actually. What do we use them for? We said they are used for damaged heart. We said they are used for damaged heart. And when you think of damaged heart, what do you think about? You think about MI, right? So they're used for post-MI arrhythmias. So when you're doing your questions, they're going to give you a patient that had chest pain and whatever for more than 30 minutes and all that. Troponins are high, which of the following drugs will you give this patient to prevent arrhythmia in these patients? You want to use class 1B antiarrhythmic medications. The second thing they are used for is to treat digoxin-induced arrhythmias. To treat digoxin-induced arrhythmias. Finally, we have class 1C medications. Class 1C medications we said are used for dying heart. These guys have very little effect on action potential duration. Very little effect on action potential duration or even your effective refractory period. That's class 1C medication. Very little effect on action potential duration or even effective refractory period. So if we have a primary graph like that, when you give class 1C medications, you're just going to have maybe the first slope because it's still blocking sodium channels, but everything else is pretty much going to overlap. Look at that. Everything else is pretty much going to overlap. So there's really no change in the length of anything. No change to action potential. No change to effective refractory period, right? They have potassium channel blocking effect as well. You want to know that. They have a bit of potassium channel blocking. What are the medications under class 1C? We have flecainide, tocainide. Tocainide is like flecainide, basically, the same suffix. And then propafenone. So flecainide, tocainide, propafenone, you want to remember. The side effect of these medications may be pretty interesting because they're supposed to be antiarrhythmics, but their side effect is that they themselves are pro-arrhythmics. So you see why they're not drug of choice, really. They are like last resort most of the time. And then you want to know that these medications are contraindicated in patients with structural and ischemic heart defects. Right? People with structural and ischemic heart defects. So if someone has MI, you are not giving them class 1C medication. If someone has an MI, you are not giving them a class 1C antiarrhythmic medication. The question becomes, what do we use class 1C medications for? What do we use class 1C medications for? We could use them for supraventricular tachycardias, but you can imagine that you're more likely to use class 1A and maybe use them as last resort, if at all. And including atrial fibrillation, you could actually use them for AFib. All right, those are your class 1A, class 1B, and class 1C medication. Remember that all these medications ultimately are actually working on your Purkinje fibers and your ventricular fibers. So class 1A medications, and really most of the antiarrhythmics you're going to be talking about, are working on your ventricular and Purkinje tissue. Basically, cardiac myocytes and its electrical innervation, right? Because we have some medications that will actually work on the SA nodes themselves and the AV nodes, and we'll see all of those eventually. All right, class 2 antiarrhythmics are beta blockers, and we'll see their activity on the AV node, especially. We'll see the activity on the AV node. We have phase 4, we have phase 0, we have phase 3, and then we are back to resting phase 4. So right here, you already see a difference between the waveform for the AV nodal electric potential or action potential versus that for the myocardial action potential. Phase 4 here is actually as a result of opening of funny, and you need to know this, T-type, guess we should write this somewhere else. It's a result of opening of funny T-type calcium channels. Funny T-type calcium channels. And I asked you in the last video, if you remember, what association you can make with T cells. And if you remember, we talked about etosuximide, right? The medication or the drug of choice for absence seizures. And they want you to remember specifically that etosuximide works in the thalamus. That's a USMLE question that can be asked. Etosuximide works in the thalamus. Okay, so funny T-type calcium channels are responsible for phase 4 action potential in the SA node. Then we have phase 0 right here. Phase 0 is dependent on L-type calcium channels. That's primarily, right? That's the major player here. L-type calcium channels. And then we also have some sodium channels that play a role. You want to also bear that in mind. Phase 3 is depolarization, or rather repolarization, right? Phase 3 is the repolarizing phase. And every time we say repolarization, every time there is a dip in action potential, you always think of calcium and potassium. And here we are going to have voltage-gated potassium channels. Let's see. We think of voltage-gated potassium channels. All right. So you want to remember those. We said phase 4, calcium channels. Phase 0, calcium channels, but different types, and sodium. And then phase 3, voltage-gated calcium or potassium channels, rather. Potassium channels. Now, when people take beta blockers, we have the slope of phase 4 becomes less steep. That's the first thing you want to notice. The slope of phase 4 becomes less steep, becomes prolonged as well. And then the flow of action potential through the AV node is also reduced. So notice that while we have a sharp dip over here, we have a slower course over here. This arc form represents prolonged AV node repolarization. Prolonged AV node repolarization. What it simply means is that it's going to take longer for action potential to flow through the AV node. It will take longer for action potential to flow through the AV node. And so we'll get this wave form. The other thing you're going to see with beta blocker use is that there's going to be an increase in the PRO interval on EKG. And we'll see more about this when we talk about the EKG. You'd remember that the PRO interval is the time frame, or represents the time frame between atrial depolarization and ventricular depolarization. So if you prolong AV node repolarization, automatically your PRO interval increases, because technically the PRO interval actually represents what? AV nodal delay. We'll see more on this when we do the EKG. So PRO interval indicates AV nodal delay. PRO interval represents the time between atrial depolarization and ventricular depolarization. Atrial depolarization and ventricular depolarization. So we want to look at example of medications that are going to pass as beta blockers. Of course, we have these specific beta 1 specific medications like metoprolol, esmolol, atenolol, right? Those are beta 1 specific for the heart. We have other beta 1 medications that are not specific, like propranolol. Propranolol works on a variety of receptors. And then we have those of them that have both alpha 1 and beta 1 activity. Medications like carvedilol, right? Labetalol. What you would notice here is that these medications that have wider activity, alpha 1, beta 1 activity, don't end in O-lol. They end in E-lol, carvedilol, and labetalol, alol and E-lol, right? So carvedilol and labetalol have both beta 1 activity and alpha 1 activity. And you want to remember that. Metoprolol, esmolol are beta 1 specific. So how do you remember them? You may remember your simple mnemonics A to M. Those of them that are A to M are beta 1 specific. Those of them that are M upwards or N upwards, something of that nature, are going to be more generalized, like propranolol, that's P. Metoprolol, esmolol, atenolol. Atenolol is also going to be what? Pretty specific, right? So you can add atenolol here. They can give you any medication, BC-olol, Lola-olol, whatever. Anything that is before M, just imagine that it's going to be beta 1 specific and work on the heart. And the cardiologists would probably prefer this medication, right? Now we want to look at the mechanism of action of these medications. We've already described that before, but let's actually take notes on that. How exactly are these medications carrying out their activity? By blocking the beta 1 receptors on the heart, these medications inhibit SA node and AV node activity. They inhibit SA node and AV nodal activity. And what's the function of the SA node? Automaticity. What's the function of the AV node? Slight delay in action potential transmission between the atrium and the ventricle. So by inhibiting SA node and AV node activity, they actually technically slow down the heart. You could think of it that way. They slow down the heart. The other thing they do is, of course, inhibit beta 1 receptors. And by so doing, they decrease CAMP and decrease what? Calcium currents. They decrease CAMP and decrease calcium currents. So the amount of calcium coming into the cell is decreased. And if you remember, calcium is responsible for contractility. So if you have less calcium coming into the cell, you decrease contractility of the heart. So you see how beta blockers depress the heart. First, they can decrease the heart rate, inotropy, And then they can decrease the strength of contractility by decreasing calcium currents into the myocardium. And then when we look at this graph here, you will see that they decrease the slope of phase 4. So instead of having a steep phase 4, we have a smaller slope or a less steep slope for phase 4. So we could add that there. They decrease the slope of phase 4. And finally, we already established that they increase the PR interval. They prolong the PR interval. Now we have to talk about side effects. Obviously, for all these medications, we like to highlight their side effects. What are the side effects of beta blockers? Now, there are beta receptors in other parts of the body. One of those areas is going to be the bronchi, the respiratory tree, right? When you consider the respiratory tree, we have a lot of beta receptors there, and their function is bronchodilation. Beta 2 receptors especially, their function is what? Bronchodilation. So when you give beta blockers, especially the wide-acting ones like propranolol, there's a potential or a likelihood that you're going to be occluding or blocking those beta 2 receptors in the respiratory tract, and that will cause bronchoconstriction, right? Bronchoconstriction. Bronchoconstriction. Now, having bronchoconstriction is not just where the problem is. The problem is if this bronchoconstriction is occurring in a patient with asthma or a patient with COPD, then we have a problem. So beta blockers, therefore, can cause asthma or COPD exacerbation. An asthma patient with bronchoconstriction is going to be in trouble. So we'll be careful with these medications in asthma patients. The next thing that they are thought to cause is impotence. This is not going to be a high point on your exam, because actually most patients that are on beta blockers that develop impotence, especially if they've had myocardial infarction before, it's thought that they are more likely having erectile dysfunction or impotence as a result of psychiatric kind of thinking. So it's in their head, sort of, right? When you have an MI, you are a little careful about increasing your heart rate or doing anything that increases your heart rate. So beta blockers have a role there, but there's also a psychological kind of component to it, making this a not so big point on your exam. But bronchoconstriction, very important. They will slow down the heart rate, and if they slow it down too much, the patient may develop bradycardia. The patient may develop bradycardia. They will block your AV node and increase PR interval. If they block it too much, the patient is going to develop AV block. That's heart block right there. And then finally, they can actually cause heart failure. They can actually cause heart failure. One of the other things that beta blockers do that you need to know is that they can mask the effects of hypoglycemia. They can mask hypoglycemia. Now, when people have hypoglycemia, you're going to have symptoms like increased heart rate, right? And general symptoms surrounding hypoglycemia. If a person is taking beta blockers and they're supposed to have increased heart rate, and beta blockers are suppressing their heart rate, there's no way then that we'll be able to tell that this person has hypoglycemia. If they're supposed to be sweating, but because of the effect of the beta blockers, they are not sweating. If they're supposed to be shaky or trembling, and because of the effect of the beta blocker, they are calm, they're not shaking, they're not trembling, then we wouldn't be able to tell that they have hypoglycemia. You have the beta blocker masking the signs and symptoms of hypoglycemia, right? And then we have specific side effects that you may want to know. For example, you want to remember that metoprolol causes lipid abnormalities for some reason. Metoprolol causes lipid abnormality. You may want to know that propranolol can worsen Prince metal angina. Metoprolol can cause lipid abnormalities, and propranolol can worsen Prince metal angina. You want to bear all of those things in mind. The next question becomes, what if your patient overdoses on beta blockers? How do we manage beta blocker overdose? How do we manage beta blocker overdose? Two medications you have to remember. One is glucagon. The second is atropine. Glucagon and atropine. If a patient overdoses on beta blockers, you use glucagon and or atropine. All right, then a few things you want to remember. Whenever they give you a patient with bradycardia on this exam, now there are dynamics to this, but for your step one, whenever they give you a patient with bradycardia, treat him with atropine. They give you a patient straight up, they just tell you this patient has decreased heart rate. It will almost be a very clear question for you. You should remember that you use atropine. I hope you remember where else you may be needing atropine. You remember you use atropine to treat what disease? I hope you said organophosphate poisoning. I hope you said organophosphate poisoning. For organophosphate poisoning, again, use atropine. What else can you use atropine to treat? Are you thinking of physostigmine toxicity? Or overdose? Again, use atropine. Use atropine. So you want to remember these are actually key areas that you're going to be tested on. With organophosphate poisoning, they may tell you that the patient already took atropine. So if the patient already took atropine, they will ask you which other medication could you have given to this patient, and you want to remember it's pralidoxime, right? And for physostigmine toxicity, you're using atropine. Remember also that for atropine toxicity, you will use physostigmine. These are simple associations and correlations you can make, and it will help you remember more information. So that was class 2 antiarrhythmics, beta blockers. The next set of medications we are going to look at are class 3 antiarrhythmic medications. And class 3 medications are potassium channel blockers. How to spell blockers? Potassium channel blockers. These medications include amiodarone, sotalol, ibutilide, right? And you can add dofetilide, but ibutilide and dofetilide are really similar medications. These are potassium channel blockers. So if I drew the myocardial action potential graph, where do you think these medications are going to function? What part of this graph do you think these medications are going to work on? Is it on phase 4, phase 0, phase 1, phase 2, phase 3, or back to phase 4? Where do you think class 3 antiarrhythmic medications are going to work? I hope you are shouting phase 3, phase 3, phase 3. Because if they are potassium channel blockers, then obviously they're going to work wherever potassium works. Maybe some of you are thinking, how about phase 1? Yes, they could also have effect on phase 1. But the biggest or significant effect we are looking at is their effect on phase 3. If they block potassium channels on phase 3, there will be a slower movement or slower efflux of potassium channels. There will be slower efflux of potassium channels. I hope you remember that. If you have slower efflux, you would have slower repolarization. So instead of having this very quick or sharp dip in action potential, what we are going to have is a slower progression, something of this nature, showing that the potassium channels are inhibited. So there's slower movement of potassium, meaning that the myocardial cell is going to come slower to resting potential. What do we call this phase? This is the repolarization phase. So there will be prolonged. The first effect of these medications you want to know is that there's prolonged phase 3 repolarization. Prolonged phase 3 repolarization. If phase 3 repolarization is prolonged, automatically it takes longer time for this action potential to be executed. So we know automatically that class 3 antiarrhythmic medications are going to increase action potential duration. What else is going to happen? The effective refractory period, this length of time, the effective refractory period is also prolonged. One other activity of phase 1 and phase 3 medications that you have to know, or class 3 medications that you have to know, is that they increase QT interval. And if you remember anything about your class 1 drugs that we saw before, it's that when they increase QT interval, they also increase risk for what? Torsades de pointes. The increased risk of torsades de pointes. That is important. These medications are used for 3 major purposes that you have to remember. One is for atrial fibrillation. The second is for atrial flutter. And the third is for ventricular tachycardia. Ventricular tachycardia. Now, for ventricular tachycardia, you may want to remember that it's primarily amiodarone and sotalol that have this activity. Primarily amiodarone and sotalol that have ability to manage ventricular tachycardia. The other important part of these medications for your exam is really their side effects. These medications have extensive side effects that a lot of questions could be asked from this area. The first medication we are going to consider is amiodarone. What you notice about this class of medication is that they are all completely different type of drugs performing class 3 effects. Amiodarone, when you look at the name amiodarone, in this name you would see iode, this IOD right here. What that tells you is that there is an iodine molecule. That should remind you that amiodarone contains this iodine particle that could become problematic in the patient, actually. There are a number of side effects attributable to amiodarone. One of them is pulmonary fibrosis. Pulmonary fibrosis. If this medication is able to cause pulmonary fibrosis, then you're probably going to do pulmonary function tests, right? The second is hepatotoxicity. If it's able to cause hepatotoxicity, you may want to do liver function tests. The third is thyrotoxicity. I mean, if the medication contains iodine, you can naturally think that iodine, thyroid gland, is there a relationship? Quite makes sense, right? And again, we have to look at thyroid function tests in these patients. Amiodarone also tends to cause some neurological and gastrointestinal side effects, but those are probably not the biggest things to worry about. Do you remember other medications that cause pulmonary fibrosis? Other medications that would cause pulmonary fibrosis. Are you thinking of bleomycin? These are important medications on your exam. Are you thinking of busulfan? Are you thinking of methotrexate? These are all medications that will cause pulmonary fibrosis. And then there's one special medication you may need to just hear. It's not big on the USMLE at all. It's metisagide. Metisagide actually causes retroperitoneal, so not pulmonary fibrosis, but retroperitoneal fibrosis. You want to remember these medications for that. Let's see, I can't draw a rectangle. All right, so bleomycin, busulfan, methotrexate will cause pulmonary fibrosis. Metisagide will cause retroperitoneal fibrosis. You want to bear these in mind. Amiodarone will cause hepatotoxicity. For that, we want to do liver function tests. It's going to cause thyrotoxicity. And for that, we want to do thyroid function test. The other thing amiodarone could do is make patients look like this. This right here. Amiodarone could produce this kind of appearance. This kind of appearance. Hyperpigmentation of the skin and this bluish grayish discoloration. This kind of appearance is described as smooth skin. It's called smooth skin. It's blue, gray skin deposits and discoloration, right? They're also going to have photodermatitis. They're also going to have photodermatitis. This is classic amiodarone effect. You want to remember that. It will also result in some corneal deposits. So it's basically depositing in the skin, depositing in the cornea, probably depositing in the thyroid gland, and literally all over the body. We have other effects of these medications like CVS, cardiovascular depression. Amiodarone will cause bradycardia. You remember the medication we said you used to treat bradycardia. I hope you said atropine. All right, it would cause heart block. I mean, if it can slow the heart, it can slow it enough that it's almost completely stopped. And then ultimately, it can cause heart failure. So these are no medications that we just give to patients and then walk away without looking back. The other medication you want to consider is sotalol, because these two tend to have the biggest side effects, right? So you want to actually remember amiodarone and sotalol, especially in this class. Sotalol, alol. Does that sound like a beta blocker to you? Exactly. Meaning that while you're giving a patient sotalol, because you want sotalol to act as a class 3 antiarrhythmic medication, it could actually still be exerting some beta blocking effects. And those beta blocking effects would become a side effect. So sotalol has strong beta blocking effects, right? Strong beta blocking effect. Another thing you want to know is that these medications cause torsades, the point, but we have more torsades with, I think with sotalol. We have torsades, the points, more with sotalol and ibutylide, right? More with sotalol and ibutylide. Amiodarone does not cause torsades, the points, like the other medications do, right? Like the other medications do. So you want to remember these about these medications. And those are class 3 antiarrhythmics. Next, we are going to talk about class 4 antiarrhythmic medications. Class 4 antiarrhythmic medications are calcium channel blockers. Calcium channel blockers. They constitute 2 medications that you have to know: verapamil and diltiazem. They constitute 2 medications that you have to know: verapamil and diltiazem. All right. What do you need to remember about these medications? When you block calcium channels, let's look at the AC node, AV node, action potential plot and see what we have. This, right? This is what it usually, or they look like generally. This is what they look like generally. If you remember the labeling we gave here before, we gave this to phase 4, 0, 3, and back to 4. I hope you remember that from previous lectures that we had. Phase 4, phase 0, phase 3, and back to phase 4. We had said previously that phase 1 and 2 that you had with your myocardial action potential, we are missing here. All right, so that is class 4 antiarrhythmic medications. When someone takes these medications, what changes do we expect to see? Or what changes do we actually see? First, there is a slow rise of action potential. If you remember what we said before, phase 0 and phase 4, actually, phase 4 was calcium channels. Phase 0 was also predominantly calcium channels. So you can imagine that the slope of phase 0 here is going to be less steep. So instead of going up in this manner, it's going to go up in this manner. Slower or less steep phase 4. And then we actually have prolonged repolarization at the AV node. So it takes longer for us to have the movement of action potential across the AV node altogether. It takes longer to form the first slope. It takes longer to repolarize the cell. That's what you want to remember here. So right here, what you need to take note of is that there's a slow rise of action potential. And what you notice here is this dip. And we said our dip is always due to potassium. And this will be prolonged repolarization of the AV node. Prolonged repolarization of the AV node. The next thing you want to know about this medication is the effect. So if it's causing a slow rise in action potential, prolonging repolarization of the AV node, what do you expect to happen to the PR interval? We said the PR interval is what? AV node, that the time between AV nodal depolarization and ventricular depolarization. So if AV nodal activity is decreased or prolonged, what happens to the PR interval? You expect the PR interval to also be prolonged. So we have prolonged PR interval. What should happen to the effective refractory period? Well, we went from having this perhaps to having something this long. So we expect that our effective refractory period is also going to be increased. What can you say about the ability of the AV node in this case to conduct action potential? Is it increased or decreased? I think we can agree that there is decrease in conduction. I mean, if you're supposed to conduct at this rate and it's taking you this much longer to conduct, now we know we can say there's decreased conduction velocity at the AV node. Decreased conduction velocity at the AV node. You want to remember these information for calcium channel blockers. But even more important than that is their side effect. What are the side effects of calcium channel blockers? Constipation. Calcium and constipation, I'm sure you've heard that a lot, even from endocrinology. Flushing can occur. Edema, peripheral edema, might occur. There may be, obviously, there will be severe depression because you're slowing down the AV node. And if you remember from what we did before, whenever you're slowing down the AV node, you could slow it down too much and the patient will develop an AV block. You could slow it down even further and give them a heart failure. And of course, we can have sinus nodal depression. So SA node depression, AV node depression. You want to remember this information for calcium channel blockers. What do we use these medications for? Do they have application anywhere? Obviously, we use them for atrial fibrillation, and we also use them to prevent supraventricular tachycardia. You want to remember these medications. Very easy. class 4 antiarrhythmics, calcium channel blockers, verapamil, and diltiazem. Verapamil and diltiazem. Do you know the difference between verapamil and diltiazem and the other calcium channel blockers? Do you remember that the other calcium channel blockers are dihydropyridine medications, whereas verapamil and diltiazem are non-dihydropyridine medications? So remember that. It's often confusing for a lot of students, but remember that verapamil and diltiazem are non-dihydropyridine medications. Just imagine we have more dihydropyridine medications, and these ones are the outcasts. There are just 2 of them, right? So they are non-dihydropyridine. All right, I'll see you in the next video. All right, let's talk about antihyperlipidemic drugs. Antihyperlipidemic drugs or antilipidemic drugs. These are basically medications that you're going to use to control blood cholesterol level, blood triglyceride level, and stuff like that, right? LDL levels and those kind of things. Now, if someone has excessive cholesterol, high blood cholesterol level, high LDL, high HDL, how are you going to control the amount of lipids, or the amount of cholesterol in their blood? A number of ways. You may be thinking of how about they stop eating cholesterol-rich foods or taking in excessive amounts of fats. How about they modify their diet and don't eat fat, right? So we'll explore the different options. How would you help somebody reduce their blood cholesterol level? 1, decrease intake of cholesterol, right? Stop eating cholesterol. Sounds simple. The second alternative is, what if they eat cholesterol and they get satisfied because people like to eat, but there is a way we can actually make this cholesterol not end up in their blood. So they eat it, they feel good, and they pass it out in the toilet, right? What if we have such a medication to prevent absorption of cholesterol? A medication that would prevent absorption of cholesterol. That would be great. And we actually have a medication for that. So somebody sat down and thought, okay, let's decrease intake, which is what we do most of the time. We try to say, okay, eat less of this, less of that, and stuff like that. The other alternative would be try to prevent them from absorbing it in their body. Is there a way we could make them store cholesterol? So when they eat cholesterol-rich foods, how about these foods actually go into storage? So it ends up in the fat. Let's put it in storage instead of having it circulating around the blood. Is that something we can do? Perhaps. But there's an alternative, or one other variable that we must consider. The liver, the body itself, makes cholesterol. There's de novo cholesterol synthesis. What this means is that people do not need to eat excess cholesterol to have high blood cholesterol levels. You may eat excess sugar, and the liver somehow is able to convert this sugar into cholesterol in the form of VLDL. We'll look at that in a bit. So how about we inhibit de novo cholesterol synthesis? Let's stop the liver, perhaps, as much as we can from producing more and more cholesterol. Is that something we can do? Then you think about how cholesterol is absorbed. We forgot to mention, or we'll just put it under absorption. What if we inhibit what they use to absorb cholesterol? In this case, bile acids, right? So we need bile to absorb fat. How about we inhibit bile? There are a lot of ways to manage patients, and this is the same rule for pharmacology. Every time you're thinking of a medication to do anything, think of what is happening and how you can stop what is happening. That's all pharmacology is all about. So if you're going to treat antilipidemic drug, we'll start from the beginning. People eat these cholesterol-rich foods and stuff? How can we prevent them from eating it? Just tell them not to eat. How can we prevent them from absorbing it? That is one alternative. And then how can we put more of it into storage and remove it from circulation? How can we inhibit de novo cholesterol synthesis? And we'll see how we play around with all of these ideas. So the first thing that happens is that people, we'll call this pathway A, is that people eat cholesterol-rich foods. When they eat these cholesterol-rich foods, these foods will be absorbed into intestinal cells. These foods will be absorbed into intestinal cells. So we'd call this area absorption. You may remember that for you to absorb cholesterol, you need bile acids. You need bile acids to absorb cholesterol. When cholesterol gets into the cell, it is formed or it is molded into chylomicrons, right? And these chylomicrons contain free fatty acids, triglyceride, and of course, cholesterol. Chylomicrons contain free fatty acids, triglycerides, and cholesterol. This chylomicron is going to be absorbed or taken into the lymphatics, right? It goes into the lymphatics, the lymphatic system. And from the lymphatic system, the chylomicrons continue into the blood. The chylomicrons continue into the blood. While they are in the blood, a number of things occur. When we do biochemistry, we'll talk a little more about this. HDL comes along, donates ApoE, ApoC2 to chylomicron, and then this chylomicron uses this ApoE and ApoC2 to interact with certain enzymes to help remove some fat and cholesterol from chylomicrons. It doesn't matter. All you need to know is that while chylomicrons get into the blood, some fatty acids will be removed from chylomicrons into adipose tissue for storage. Into adipose tissue for storage. The enzyme that will help this process is lipoprotein lipase. The enzyme that will help this process is lipoprotein lipase. LPL. Lipoprotein lipase. It will help propagate storage. This process is storage. You store free fatty acids in adipose tissue, right? Now, that is one pathway we can follow. Eat cholesterol, store it as fat. We don't need it circulating in blood. Store as much of it as possible as fat. But that is not what always is the case, because oftentimes this fat can be broken down, or this adipose tissue can be broken down by hormone-sensitive lipase. Hormone-sensitive lipase. We don't usually write an abbreviation for this guy, so that's okay, right? Hormone-sensitive lipase. And when you break it down, you get free fatty acids again in the blood. And this is something you probably don't want to happen. So what we let's call this part lipolysis, right? Let's call this lipolysis. So let's get back to the beginning. We started with someone eating food containing cholesterol, and then it becomes chylomicrons, which contain all of this. And then chylomicrons end up in the lymphatics, which end up in the blood, and then storage in adipose tissues and free fatty acids. Whatever is left is just going to remain in the blood. Is there a way we can decrease the amount of cholesterol that ends up in this patient's blood? Someone came up with an idea. What if we can actually inhibit absorption? So this person eats cholesterol, but we are going to try to block the absorption of cholesterol at the intestines, at the brush border. And so they made the medication ezetimibe. So what ezetimibe does is inhibit absorption of cholesterol. It prevents cholesterol absorption at the intestines. For you to absorb cholesterol, you need bile acids. Now we are going to talk about bile acid synthesis eventually. When you make bile acids are made in the liver from cholesterol. The liver makes bile acids from cholesterol. So somebody thought, usually when we eat fatty foods, we use bile acids to reabsorb the fatty foods. And then these bile acids are recycled, meaning we don't waste them. They are recycled and reused again. So if we can waste the bile acids, remember, we use cholesterol to make bile acids. So if we inhibit the bile acids, waste them, throw them away, then the liver will be forced to use more cholesterol to make more bile acids. And as your liver uses more cholesterol to make more bile acids, what's going on? You're using your cholesterol. You're removing cholesterol from the blood. So we take that again. We have bile acids. Bile acids are made from cholesterol. Usually, they are recycled. If we can waste the bile acid, we don't get to recycle it anymore. The liver will be forced to use more cholesterol to make bile acids instead of dumping this cholesterol in the blood. And so we made medications to help us waste bile acids and throw them away. And we call those medications the bile acid resins. Medications in this class will include cholestyramine and cholesterol. Cholestyramine and cholesterol. These are bile acid resins. These medications are made to inhibit what? Bile. They are made to inhibit bile. They are going to waste bile acids, and then the liver will be forced to make more bile acids, and then we would have less cholesterol in the blood. Beautiful idea. The next thing that happened here is that chylomicrons went into the lymphatics, and from the lymphatics, they're actually going to go into blood via the thoracic duct, right? They'll go into blood via the thoracic duct. I want to actually remember this because there's a pathology associated with the thoracic duct. I hope you remember that. The pathology associated with the thoracic duct. When there is damage to the thoracic duct, fluid is going to leak out of the thoracic duct into the pleural cavity, and that is what we call chylothorax. Those whitish, milkish fluid that leaks out of the thoracic duct into the pleural cavity. When that happens, we'd call that a chylothorax. You may want to just remember that because sometimes you're going to see a question on that concept. The next thing we want to think about is lipoprotein lipase. We said lipoprotein lipase helps move cholesterol from blood into storage. Lipoprotein lipase helps move cholesterol from blood into storage. We don't want cholesterol excessively in the blood. So how about we give a medication that's going to help activate lipoprotein lipase the more? Activate lipoprotein lipase the more, so that more free fatty acids can be put into storage. And so we made a medication to upregulate lipoprotein lipase. To upregulate lipoprotein lipase. That medication was the fibrates. The fibrates, medications like gemfibrozil. These medications will upregulate lipoprotein lipase and put free fatty acids into storage, taking them away from the blood. That is very important. Finally, we talked about this adipose tissue. We said this adipose tissue may be broken down, right? So after we've stored our fats, the body can still break down these fats with the help of the hormone-sensitive lipase. The body can break down adipose lipolysis with the help of this enzyme, hormone-sensitive lipase. So somebody thought, what if we can inhibit hormone-sensitive lipase? Let's give a medication that can inhibit hormone-sensitive lipase, inhibit lipolysis, and that medication was niacin. We'll talk about all of these medications in summary after now. But you see how people come up with these medications that work at different points. Whenever you think of a problem, you think of any point at all along the pathway that you can target for treatment. And that is how treatments are brought about, or medications are brought about generally. The second pathway, which we'll call pathway B here, is the part where the liver itself, our body itself, is actually making cholesterol. Our body makes cholesterol. The liver makes cholesterol. So you could eat carbohydrates. If you remember the glycolytic pathway, the body takes glucose, makes it into glucose 6-phosphate, fructose 6-phosphate, and then we go through all glucose fructose 2,6-bisphosphonate and all that. We go through the glycolytic pathway, and we ended up with pyruvate. And then pyruvate went into the link reaction with pyruvate dehydrogenase and produced acetyl-CoA. Acetyl-CoA can be used to make a wide variety of things. It could go into the Krebs cycle, it could go into the cholesterol synthesis pathway, and so on and so forth. So the liver could also take acetyl-CoA. The liver could take acetyl-CoA, convert acetyl-CoA into HMG-CoA, convert HMG-CoA into mevalonic acid, and mevalonic acid into cholesterol. Mevalonic acid into cholesterol. I think we need a much bigger liver, perhaps. Let's see if we can make our liver. All right. So let's say that is the liver, right? That's how the liver makes cholesterol. Now, when the liver makes cholesterol, there are a number of things that could happen to this cholesterol. Normally, the liver could release some of it into the blood. Remember, we already said it could make bile from it. The liver can use cholesterol to make bile, but we are more interested in this here. The liver can use cholesterol to make VLDL, very low density lipoprotein. You see how these guys play a role later in biochemistry. The liver can convert cholesterol to VLDL, and then this VLDL will be released into the blood. This VLDL will be released into the blood. VLDL contains cholesterol, and eventually when you break down VLDL, you're actually going to end up with LDL. You look at the biochemical mechanism when we do biochemistry, you get to LDL. If VLDL is ultimately going to create LDL, which is bad cholesterol, which is cholesterol that we don't want, is there a way perhaps that we can inhibit the synthesis of VLDL, especially in patients with hypercholesterolemia or dyslipidemia as a whole? Is there a way we can inhibit the synthesis of VLDL? That's another place we can target for treatment. And yes, there is. The medication, again, is niacin. So you'd see niacin inhibiting hormone-sensitive lipase and niacin inhibiting VLDL synthesis. Please bear that in mind. It's going to be important. The other thing you want to know is that the liver can get cholesterol. So here we see the liver using cholesterol to make VLDL. It could use cholesterol to make bile. I'll just put it right here. You remember we said it uses cholesterol to make bile. That's why we gave these bile acid resins, so that when we waste the bile, the liver will be forced to use more cholesterol to make more bile to replace the bile we are wasting with our cholestyramine and cholesterol, right? And so we have less cholesterol to put in the blood. Makes sense. The other alternative is that the liver could collect cholesterol from the blood. How? we have receptors on the surface of the liver. We have receptors on the surface of the liver, like that. And they collect cholesterol into the liver in the form of LDL. In the form of LDL. Therefore, these receptors are LDL receptors. These receptors are LDL receptors. So the liver uses its LDL receptors to remove LDL from the blood. You want to remember that. The liver uses its LDL receptor to remove LDL from the blood. You want to remember that. All right. Now, what if we can give a medication that will stop the liver from making cholesterol? So here, where the liver makes HMG-CoA to methylmalonic acid, the enzyme is HMG-CoA reductase, right? The enzyme that works here, which is the only one we need to remember, the rate-limiting enzyme, is HMG-CoA reductase. If we can block HMG-CoA reductase, what do you think is going to happen? The liver is going to try to get cholesterol from other sources. So it will collect more and more cholesterol from the blood. If we can inhibit HMG-CoA reductase, the liver will be unable to make its own cholesterol. If the liver cannot make cholesterol, it will be forced to collect cholesterol from the blood, to remove cholesterol from the blood in the form of LDL. That is great. That is what we are looking for. The medications that we can use to inhibit HMG-CoA reductase are the statins. The medications that we could use are statins. So statins are HMG-CoA reductase inhibitors. Whenever a patient uses statins, the liver picks up more LDL from the blood. How does it do that? It can decide to express more and more LDL receptors. So there's upregulation of these LDL receptors when patients use statins. The next thing you want to think about is this. We have enzymes. These receptors are not expressed forever or permanently, right? They are broken down. These LDL receptors are often broken down. So they have their own inhibitors. The enzyme that breaks down LDL receptors is the PCSK9 enzyme. The PCSK9 enzyme. This enzyme inhibits LDL receptors. What if we could get rid of the PCSK9 enzyme? Then we would have more LDL receptors. And that means our liver will be able to take up more LDL from the blood. And that would also mean we would have less cholesterol in the blood, or less LDL in the blood. Makes sense? PCSK9 enzyme inhibits LDL receptors. If we can take away the PCSK9 enzyme, what that means automatically is that we would have more LDL receptors. If we have more LDL receptors, our liver will be able to take up more cholesterol, more LDL from the blood, which is what we are looking to achieve. The medications that inhibit PCSK9 enzymes are called PCSK9 inhibitors. Sounds rather obvious. Or PCSK9 inhibitors. We have medications like alirocumab and evolocumab. Alirocumab and evolocumab. What we've done is actually go through all the medications that we use that are important for managing hyperlipidemia. The medications that are very important for managing hyperlipidemia. We said we could stop absorption using ezetimibe. We could waste bile so that the liver makes more bile acids from cholesterol using bile acid resins, cholestyramine, cholestyramine. We reminded ourselves of chylothorax, which can occur when there is damage to the thoracic duct. You remember the thoracic duct joins the bloodstream around the left shoulder area, right? The junction between the subclavian and the jugular. internal jugular. All right. We saw lipoprotein lipase store cholesterol and free fatty acids as adipose in adipose tissue. And we said we could make that happen even more with the help of fibrates activating lipoprotein lipase. We said people may have breakdown of their adipose tissue to release free fatty acids because of the activity of hormone-sensitive lipase. And we said we could inhibit that with niacin so that we have less cholesterol in the blood. Finally, we saw the liver making cholesterol. The liver literally makes cholesterol, turns it into VLDL, and releases this VLDL into the blood. We said we could inhibit that process again using niacin. We could use niacin to stop the conversion of cholesterol to VLDL, or we could stop the synthesis of cholesterol as a whole by using statins, which are HMG-CoA reductase inhibitors. Finally, we talked about the LDL receptors. We said if people are using statins, they'll inhibit cholesterol synthesis. The liver will be forced to collect cholesterol from the bloodstream, and in the process, it will upregulate LDL receptors, produce a lot of it, and remove a lot of LDL from the blood. Remember that cholesterol could also be used to make bile. We said that before, which is why we gave bile acid resins to continue wasting cholesterol. Finally, we talked about the PCSK9 enzyme that inhibits LDL receptors, but we want LDL receptors. So we don't want anybody that is inhibiting our LDL receptors. So let's give PCSK9 inhibitors and inhibit the PCSK9 so that we can have more LDL receptors and remove more cholesterol from the blood. The other thing you would want to consider will be the side effects of these medications and a little or a few specifics that I would like you to bear in mind. Again, we started with ezetimibe. I think ezetimibe was the first medication on that list. We started with ezetimibe. Mechanism of action, we said ezetimibe prevents, just for note's sake, right? Prevents cholesterol absorption in the GI, specifically the small intestines, because you may be asked. And then we have to know the side effects of ezetimibe. Causes what? Hepatotoxicity, slightly mild, yes. And what's the second one? Causes diarrhea. You want to remember those. Then we talked about the bile acid resins, cholestyramine, cholestyramine, cholestyramine. What did we say about these medications? They waste bile. If they waste bile, like that's their mechanism of action, I guess. So they waste bile. There are bile acid resins. They are bile acid resins. What do they cause? GI upset, decreased absorption, right? Decreased absorption. Now, what you want to bear in mind is this. As cholestyramine, cholestyramine are inhibiting bile acid, you want to remember that bile acids are used to absorb fats and cholesterol, as well as fat-soluble vitamins. They are used to absorb fat and cholesterol, as well as fat-soluble vitamins. So if you are giving cholestyramine and cholestyramine and wasting the bile acids, you're also going to decrease absorption of fat-soluble vitamins. A, D, E, K. I hope you remember that those are the fat-soluble vitamins. Cholestyramine and cholestyramine, bile acid resins, that is, will inhibit or decrease the absorption of fat-soluble vitamins. You want to remember that, right? The third medications we talked about were the fibrates. We saw fibrates initially performing one mechanism of action, but we're about to see that it does even more. Do you remember the mechanism of action? Activation of lipoprotein lipase. So we can say that first, fibrates upregulate, that is, increase the activity of lipoprotein lipase, LPL. Fibrates upregulate lipoprotein lipase. The second thing fibrates do that we did not really highlight here is PPAR gamma, or I said gamma there. It should be alpha, right? PPAR alpha activation. Whenever I think of PPAR alpha, I think of another important medication, PPAR gamma. I will mention that guy in a bit. By activating PPAR alpha, fibrates increase sensitivity and the ability of tissues to actually take up these cholesterol and all of that. They increase sensitivity. You don't really need to remember much about PPAR alpha. What you just need to know is that fibrates inhibit or activate rather PPAR alpha, right? Fibrates activate PPAR alpha. All right. The other thing I wanted to mention, I think this guy is really strong in my mind, is PPAR gamma. PPAR gamma. You need to know this medication. And I hope you're thinking already that PPAR gamma reminds you of thiazolidine, this long medication. Thiazolidine, I hope I remember their names. Thiazolidine diones. Right. Thiazolidine diones. These medications are diabetic medications that are used to treat diabetes mellitus. You may remember, what do we call that drug? Rosiglitazone as a classic one. Pioglitazone. These medications are used in diabetic patients. And you remember the classic side effects they have, heart failure, especially with rosiglitazone. Patients tend to develop heart failure, but that's by the way. Let's talk about fibrates. Fibrates activate PPAR, so they are PPAR alpha agonists, right? All right, side effect of fibrates. And the pen, good. Side effects of fibrates, these medications will cause myopathy, rhabdomyolysis, really, and they also cause gallstones. They also cause gallstones. What kind of gallstones do you think they are going to cause? We are talking about cholesterol, so they're going to cause cholesterol gallstones. So how do they cause gallstones? We've seen one, upregulation of LPL, 2, PPAR alpha activation, and we're about to see a third one. You want to know that fibrates inhibit another enzyme, 7-alpha hydroxylase. Fibrates inhibit 7-alpha hydroxylase. You don't need to know much about this enzyme. 7-alpha hydroxylase, what? It's a P450 enzyme, right? It's a P450 enzyme. I've not seen this tested anywhere before. And this enzyme exists in the endoplasmic reticulum. I can remember this information clearly. And if you're going to remember the specific cytochrome they work on, which I think is not important, is cytochrome P7A1. You get that? And the role of this guy was bile acid synthesis. Bile acid synthesis and regulation. So 7-alpha hydroxylase is a P450 enzyme in the endoplasmic reticulum, specifically cytochrome P7A1, and its mechanism, or what it does, is bile acid synthesis and regulation. Now, when there's a damage to 7-alpha hydroxylase, there is increased likelihood, or increased likelihood, let's use the word likelihood, of precipitation of cholesterol. And if you have cholesterol precipitation, you're going to form cholesterol stones. These are gall stones. You want to remember that. All right, and that's that for fibrates. The third set of medication we mentioned was what? Who was number 3? Niacin. All right. The third medication we talked about was niacin. And we saw one mechanism of action of niacin here, activation of hormone-sensitive lipase, inhibition rather, of hormone-sensitive lipase. So first, niacin inhibits hormone-sensitive lipase right? And by so doing, inhibits lipolysis. It inhibits lipolysis. And then we saw niacin somewhere else. Do you remember? Niacin was inhibiting the conversion of cholesterol into VLDL. So it inhibits VLDL synthesis. It inhibits VLDL synthesis. It inhibits VLDL synthesis. Those are the two activities or actions of niacin. You want to remember that. So there'll be decreased VLDL synthesis from the liver. When you talk about side effect of niacin, you talk about flushing and all of those kind of things. Not very big. Finally, let's talk about statins quickly. Let's talk about statins. We already saw statins. These are like the biggest medications here. These guys are HMG-CoA reductase inhibitors. They're HMG-CoA reductase inhibitors. Like we saw, if they inhibit HMG-CoA reductase, you're going to decrease cholesterol synthesis in the liver. That was the first thing we established. And then we said if you inhibit cholesterol synthesis, the liver will have to find alternative sources of cholesterol, right? The liver is going to find alternative sources for cholesterol. And how does it do that? It upregulates these LDL receptors. So statins are going to cause upregulation of LDL receptor. So they increase LDL receptor expression. They increase LDL receptor expression. What else do you need to know about these guys? Let's see. So there'll be more LDL taken into the liver, and then this LDL will be broken down, of course, in the liver. So let us say, I think one of the phrases they would often use on your exam is that it increases uptake and catabolism of LDL. Next is the side effect. That happens to be quite important. Fibrates are going to also cause myopathy and hepatotoxicity. Did I say fibrates? Statins are going to cause myopathy and hepatotoxicity. And this myopathy is even worse, is accentuated, worsened, when you use them together with fibrates. It's worsened when you use them together with fibrates. And these are the medications you're going to use to manage your patients with hyperlipidemia. Please remember them. However, there are two most important things for you to take away from this particular session. That is this. On your exam, whenever they give you a patient with hypercholesterolemia, how do you spell that? You're going to treat them with a statin. You cannot forget this information. If you do, probability that you would miss a question for sure. Statins all end in statin, atorvastatin, lovastatin, doesn't matter. Whatever ends in statin is a statin. So hypercholesterolemia, cholesterol level greater than 190, 200. If it's high and they ask you what medication you'll be giving to this patient, pick a statin on this step 1. When you get to step 2, we have a little nuance to it and a number of things you need to consider. For your step 1, a patient with hypercholesterolemia gets a statin. The second thing is a patient with hypertriglyceridemia. Every patient with hypertriglyceridemia gets a fibrate. Every patient with hypertriglyceridemia gets a fibrate. You cannot make a mistake with these two. Always on the exam, you will see a question on it the very next time you practice pathology or pharmacology questions on this subject. All right, please remember the information. I will see you guys on the next one. All right, antihypertensive therapy. If you're going to treat hypertension or manage hypertension, the question to ask is what the goal of therapy is. And this is actually the question you're supposed to be asking every time you think of pharmacological management. If you're going to give a medication, what you should be thinking is what is going on in this disease process and what am I trying to achieve with this particular therapy? In this case, we are looking at your antihypertensive therapy. Antihypertensive means we are trying to bring down pressure. The goal of management in using antihypertensive therapies is going to be to decrease blood pressure. To decrease blood pressure. That is the goal of antihypertensive therapies. And there are 2 ways that we can decrease blood pressure. We can decrease blood pressure by decreasing blood volume. Just think of it like you have a water pipe and you have water flowing in that pipe. If you reduce the amount of water that flows through the pipe, the pressure within the pipe will drop, right? So by decreasing volume, we can manage blood pressure. The other way is to increase the radius or the diameter, whichever one you use, of blood vessels. Basically, vasodilation. Basically, vasodilation. So these are the 2 major ways to reduce blood pressure. It's like, again, the pipe analogy. If you're having a water pipe, a small water pipe versus a wide water pipe, with the same volume of water flowing in both of them, the same volume of water will flow at lower pressure in a bigger pipe. Similarly, if we can make these blood vessels bigger, perhaps blood will flow at lower pressure. And that is what vasodilation does. That is what vasodilation does. Remember that hypertension itself is a result of narrowing of blood vessels in most cases. So when people have hypertension, many of the time, there's actually narrowing of the blood vessels. The blood vessels, either due to aging, become stiff, or so that would be naturally due to aging, they decrease elasticity, they become stiffer. The second thought process is going to be that because of peripheral vasoconstriction, as a result of peripheral vasoconstriction, these blood vessels will have increased pressure of blood within them simply because they are narrower. And there are several reasons why there could be peripheral vasoconstriction. It could be because of increased catecholamines or sympathetic agonists, perhaps. It could be because of pathology, like what we have in renal stenosis, because of atherosclerosis. There are several reasons why people may develop narrower blood vessels. You remember that the arterioles contribute the most to total peripheral resistance. And as you increase total peripheral resistance, just to recap these points, it's equivalent to saying you increased afterload. And if you increase afterload, the heart will do more work, and so the blood pressure is also going to increase. For hypertension, there's one last thing we think about when we manage patients with hypertension, and that is the collateral damage, the extra damage that hypertension causes on certain organs like the kidneys and the heart itself. We call these processes remodeling. So you'd hear them use remodeling oftentimes. And what happens is that as you increase the pressure of blood within the kidneys and even on the heart is going to undergo hypertrophy. The kidney is going to undergo certain changes in the glomerulus in people with hypertension, especially if that patient also has diabetes. So even as we are trying to reduce the blood pressure, we are also trying to manage the long-term effects of hypertension, right? We are trying to manage the long-term effects of hypertension, and that is the purpose of antihypertensive medications. There are different patients. Majority of patients with hypertension are going to have additional diseases. There are persons that have hypertension and hypertension only. Potentially people with, say, primary hypertension. People with primary hypertension, all they have is hypertension. In this case, we can focus on volume vasodilation perhaps and manage this patient. And then we can also attempt to prevent remodeling. When we talk about remodeling, the heart tissue actually grows. Did you know that angiotensin 2, for example, grows the heart? Did you know that angiotensin 2 grows the heart? So part of management of these patients, you remember that hypertension leads to cardiovascular hypertrophy, left ventricular hypertrophy, which is growing of the heart. So if there's a way we can inhibit the chemical or something that grows the heart, you can be sure that that's going to become part of the therapy for hypertensive patients. So for primary hypertension, our focus could be volume control. If we are going to try to reduce the volume, we are going to be using diuretics. And thiazide diuretics are a very common one for you to know. Thiazide diuretics are very important. We can decide to cause vasodilation using calcium channel blockers, and we can decide to stop remodeling, to stop that additional changes using ACE inhibitors. ACE inhibitors would decrease angiotensin 2, and if we decrease angiotensin 2, then we would inhibit remodeling. If ACE inhibitors are not available for use or are not good for these patients, we can decide to use angiotensin receptor blockers. Now, what if someone has hypertension and heart failure? You realize that although we have different algorithms for what therapy to use, that would be the business of step 2CK. You'll see all of those later. But if a patient has hypertension and heart failure, if you have heart failure, you are pulling a lot of fluid within the heart. Some of this fluid will be going into the lungs. For example, they will have shortness of breath. So at every point in time, if a patient has hypertension and heart failure, you're thinking of specific findings, and we'll mention some of them that you need to take care of. Diuretics are going to be very important. And with this, I want you to remember this one thing. If they give you a patient with pulmonary edema on this exam, your go-to medication is going to be furosemide, basically loop diuretic. This is a pretty common one on your exam, so you want to know that. I think that's Lasix. Furosemide, okay? Loop diuretics for pulmonary edema. Other than that, diuretics, just like thiazide diuretics, to remove fluid and hopefully decrease pressure. The other thing we want to do is going to be to give ACE inhibitors, because we don't want the heart to undergo extra additional remodeling or ARBs where the patient cannot take ACE inhibitors. There are other therapies we may use. We may use aldosterone antagonists, medication like spironolactone. These are all under your renal. So we'll talk about more about these guys when we talk about renal. And finally, we can use beta blockers. But again, there are different algorithms. You can't use beta blockers in everybody. You only use them in people with compensated heart failure. You use them in people with compensated heart failure. If they have uncompensated heart failure, don't go close to the beta blockers. All right. And that is that, hypertension and heart failure. The other combination of conditions that people may get will be hypertension and diabetes mellitus. Hypertension and diabetes mellitus. Diabetes mellitus is one of the biggest or the worst risk factor for myocardial infarction. And when people have hypertension and diabetes, the risk increases even much more. The damage that hypertension does to the heart and potentially to the kidney is nothing close to the damage that diabetes mellitus does to the heart and to the kidney. You'd remember that diabetes mellitus causes nodular glomerulosclerosis from your renal, where you talked about Kimmel-Wilson nodules and all of those kind of things, right? Great. So when people have diabetes, there's extra need for you to actually stop remodeling. It's almost like that is now the primary concern. And of course, the hypertension is also of concern. We can decide to cause vasodilation using calcium channel blockers. We can decide to reduce volume using diuretics. Your thiazide diuretics are usually the forefront of all of these. Thiazide diuretics, and we may have need for beta blockers. Beta blockers decrease oxygen consumption of the heart, and by decreasing oxygen consumption of the heart, they decrease oxygen demand and they decrease the risk for someone developing myocardial infarction, for example. How about patients with hypertension and asthma? Imagine a patient with hypertension and asthma. Asthmatic patients have difficulty breathing, for example, right? And then they have symptoms like cough, shortness of breath, and all of those things. One of the things you have to know about ACE inhibitors is that ACE inhibitors cause cough. We'll see those medications later. ACE inhibitors cause cough as a side effect. Now, if ACE inhibitor is causing cough, and our asthmatic patient also has cough from his asthma, when you place this asthmatic patient on ACE inhibitor and he begins to cough, what is causing the cough? That's the big question. How does the doctor tell, or how does the physician differentiate between the cough for asthma and the cough as a result of using ACE inhibitors? So what do? We avoid ACE inhibitors altogether in asthmatic patients. So we go straight for angiotensin receptor blockers, ARBs. We go straight for ARBs in asthmatic patients. And then we can do our regular vasodilation with calcium channel blockers, decrease the blood volume with diuretics, like your thiazide diuretics, and we can use beta blockers. Now, beta blockers pose another challenge. Your asthmatic patients, beta blockers cause bronchoconstriction. Beta blockers cause bronchoconstriction, especially if you use beta blockers like propranolol or other beta blockers. So what can we do? In asthma patients, we can't use general beta blockers. We have to use more specific beta blockers, medications that are specific for the heart. So we use cardio-selective. It's actually better to avoid beta blockers completely in asthma patients. It's better to avoid them completely if you can in asthma patients. What if a patient is pregnant and has hypertension? We don't use all medications. Some of these medications are going to be toxic to the child because they can cross the placenta, like ACE inhibitors will cause renal defects, for example, in this child. So we have specific medications that we can use for hypertension in pregnancy. Methyl dopa is a big one. Sometimes they'll describe the mechanism of action of these medications and expect you to know them. Hydralazine is another one. Labetalol, I think. Labetalol is one, and we have nifedipine. Yes. You need to know these medications. I think students have some mnemonics that they use to remember them. If you remember them, that will be great. Again, there are two goals of hypertension therapy. One is to decrease volume. The second is to cause vasodilation. Decreasing volume is the easier part. We just give diuretics. It's sort of less complicated, I think. We give diuretics and the patient is fine. But for vasodilation, there are a lot of things that have to go on within the blood vessel for you to actually cause vasodilation. You have to know that we have two enzymes at work within any blood vessel at any given time that's work hand in hand or back and forth to cause vasoconstriction or vasodilation, depending on if you're inhibiting the enzyme or activating the enzyme, or inhibiting the other enzyme or activating the other enzyme. These enzymes are myosin light chain kinase, and myosin light chain phosphatase. You can imagine that just off their nomenclature, you can tell what they do already. Myosin light chain kinase is going to phosphorylate myosin. You remember from your biochemistry that kinases phosphorylate. Myosin light chain phosphatase is going to dephosphorylate myosin. So looking at the names of these guys already, you know the function of these two enzymes, right? Myosin light chain phosphatase, for example, you want to know, let's start with that, MLC phosphatase. Is going to dephosphorylate myosin. When it dephosphorylates myosin, it's going to result or bring about relaxation. Okay, I could just add that here. It's going to cause relaxation. It's going to dephosphorylate myosin and cause relaxation. Myosin light chain kinase, on the other hand, is going to phosphorylate myosin and cause contraction. This contraction or relaxation will cause the changes we need in the blood vessel. If you cause relaxation, we would achieve vasodilation. If you cause contraction, we will achieve vasoconstriction. We will achieve vasoconstriction. So you want to bear these simple points in mind. Now, let's talk about muscle contraction first. And let's see the different agents that play a role to cause muscle contraction, right? Let's see the different agents that play a role to cause muscle contraction. Now, the first thing that happens, that needs to happen for muscle contraction to occur, especially smooth muscle contraction, is that we need to activate myosin light chain kinase, right? We need to activate myosin light chain kinase. We need to activate it. And to do that, or to activate myosin light chain kinase, we need the calcium calmodulin complex. But we'll talk about that in one bit. If this is your cell, if this is a cell, and inside this cell, we have myosin light chain kinase over here. We have myosin light chain kinase over here. Okay, let's move him up a bit. Let's move him up a bit. We have myosin light chain kinase over here. Calcium comes into the cell. Calcium comes into the cell via some calcium channels, L-type voltage gated calcium channels. Okay, when calcium comes into the cell, calcium binds to calmodulin. We have calcium binding to calmodulin. Okay, and this calcium calmodulin complex activates myosin light chain kinase. That is one way to activate it. Calcium enters the cell. We have it binds to calmodulin. We have calcium calmodulin complex, and this complex can activate myosin light chain kinase. The second alternative is that the sarcoplasmic reticulum, which is already inside the cell, the sarcoplasmic reticulum, which is already inside the cell. One of the things you have to know is that the sarcoplasmic reticulum stores calcium. Okay, that's one of its functions, to store calcium. It can release calcium from within it, and this calcium will bind to calmodulin to form a calcium calmodulin complex, and eventually, ultimately, it will do the same thing, right? So sarcoplasmic reticulum releases calcium, calcium binds to calmodulin, and then we have this. That is another way that could happen. Now, if we are going to try to increase contractility, we need to increase calcium calmodulin complex, because that seems to be the central way to activate myosin light chain kinase. Remember, ultimately, if we activate myosin light chain kinase, we are going to cause vasoconstriction, we'll cause contractions. So if we increase calcium calmodulin complex, we would increase myosin light chain kinase activation. What can we do? Is there a way we can maybe increase the amount of calcium that is coming into the cell? If we do that, we will activate myosin light chain kinase, will increase contraction. If we increase the amount of calcium that is released from the sarcoplasmic reticulum, if we increase the amount of calcium that is coming from the sarcoplasmic reticulum, we will also increase contraction. We'll look at one of these mechanisms, right? So the easiest way to increase contraction, let's activate this sarcoplasmic reticulum. Let's activate it. Let's induce it. Let's cause it to release more calcium. The way to do that is by using a second messenger system involving IP3, inositol triphosphate. To increase the amount of IP3, which will subsequently activate or induce release of calcium from the sarcoplasmic reticulum, we need GQ-coupled receptors. We need to activate GQ-coupled receptors. And there are a number of medications that can activate your GQ receptors. You remember that GQ is basically one of the G proteins. Remember that G protein is a 7-domain protein. We'll talk about those guys somewhere down the line. All right. So by stimulating or activating these GQ receptors, we increase IP3 inositol triphosphate formation, which will in turn induce the sarcoplasmic reticulum to release calcium. You did this in general pharmacology, or you would see this in general pharmacology. There are a number of molecules that can perform this function, including the following: endothelin 1. Endothelin 1 is secreted by endothelial cells, and it can cause vasodilation, especially in the pulmonary vasculature. You may remember the medication bosentan, which was an inhibitor of endothelin 1 to treat pulmonary hypertension. The second medication, or the second chemical, is going to be epinephrine. Epinephrine, if you remember, works on multiple receptors, multiple sympathetic receptors. In this case, the alpha-1 receptor is GQ coupled. And you want to remember that your alpha-1 receptor causes vasoconstriction. Inducing your alpha-1 receptor, if you remember, causes vasoconstriction. And many times when we want to cause vasodilation, we try to inhibit alpha-1 receptor. Are there any situations you remember or you can think of where it's going to be important to actually increase activity of alpha-1 to cause vasoconstriction? Yes, when people have hypotension, perhaps, or when patients have runny nose. You remember patients with runny nose that we give them phenylephrine or pseudoephedrine. These medications are alpha-1 agonists in the nose. They will stop running nose. All right. Angiotensin 2 is also GQ coupled and is going to increase contractility and calcium release. Finally, we have vasopressin. Vasopressin is also going to cause that effect. So here you go. You have medications that can cause vasoconstriction. you have medications that can cause vasoconstriction. Another thing you want to know is that these same medications, these GQ receptors we just finished talking about, have another function that is quite important. They have a second function. So let's put GQ somewhere here as well. They have another function. These medications can still work on GQ, and what this GQ receptor does is activate another enzyme we call Rho kinase. They activate another enzyme we call Rho kinase. And the function of Rho kinase is to inhibit. Rho kinase inhibits myosin light chain phosphatase. Rho kinase inhibits myosin light chain phosphatase. You remember that we said previously that myosin light chain phosphatase causes muscle relaxation and vasodilation, right here. We talked about that just now. So by inhibiting myosin light chain phosphatase, we are preventing vasodilation. That is what Rho kinase is doing. Rho kinase is preventing vasodilation by inhibiting myosin light chain. I call it phosphatase, phosphorylase. Okay, myosin light chain phosphorylase, not phosphatase. I hope I haven't been saying phosphatase all along. Oh, shame, I've been saying phosphatase. Okay, so it's myosin light chain phosphorylase, not phosphatase, phosphorylase. Okay, myosin light chain phosphorylase. By inhibiting myosin light chain phosphorylase, Rho kinase is inhibiting or preventing vasodilation. Is preventing vasodilation. So if we can activate Rho kinase is going to cause even more inhibition of myosin light chain phosphorylase and inhibit vasodilation ultimately even the more. Rho kinase is one of these serine threonine kinases. Okay, I don't think this is very important, for example, maybe you should know it. It's one of the serine threonine kinases. And what this guy does is to regulate movement of the cells, regulate movement of cells by acting on the cytoskeleton. By acting on the cytoskeleton. I've not seen a question or heard of one about Rho kinase before, but you never know. So bear that in mind. So these GQ coupled receptors, endothelin, and all these agents potentially will also work in this manner. Activate Rho kinase, activate or inhibit myosin light chain phosphorylase, inhibit vasoconstriction or vasodilation, rather inhibit vasodilation and cause vasoconstriction. That's the ultimate goal. So these are means or mechanisms of causing muscle contraction. These are mechanisms of causing muscle contraction. What if we want to cause muscle relaxation? We are going to come back here to see one more thing. What if we want to cause muscle relaxation or vasodilation? To cause vasodilation, or muscle relaxation, smooth muscle relaxation, what can we do? We said previously that myosin light chain kinase causes contraction. Myosin light chain kinase causes contraction. So if I inhibit myosin light chain kinase, then potentially I can cause relaxation or vasodilation. So here we go. I'm going to show you two ways, okay? We are going to look at two ways. One is myosin light chain kinase. Myosin light chain kinase causes contraction. Myosin light chain phosphorylase causes relaxation. If we inhibit myosin light chain kinase, we can inhibit contraction, and that means we'll be causing relaxation or vasodilation. I hope that makes sense. If we inhibit myosin light chain kinase, we will be inhibiting contraction, which means we will be causing relaxation. There is an enzyme that does that, or a chemical that does that, and that is CAMP. CAMP is a myosin light chain kinase inhibitor. We get CAMP from AMP, adenosine monophosphate. We get CAMP from AMP, adenosine monophosphate, with the help of an enzyme, adenylyl cyclase. I hope you're thinking of where these enzymes are coming from, where you've seen these things before. With the help of an enzyme, adenylyl cyclase. After CAMP does its work, inhibits myosin light chain kinase, it is often converted back to AMP. The enzyme that converts CAMP back to AMP is phosphodiesterase, PDE3. PDE3. Now, what can we do? Our goal is to cause vasodilation. By inhibiting myosin light chain kinase, we can cause vasodilation. Just imagine that myosin light chain kinase is synonymous with vasoconstriction. So by inhibiting myosin light chain kinase, we are inhibiting vasoconstriction. What if we can increase the amount of CAMP? Let's make it double, triple the amount, so that we would inhibit vasoconstriction completely and cause a lot of vasodilation. Is there a way we can do that? Maybe if we inhibit PDE3, if we block this enzyme, it will stop converting CAMP back to AMP, and then we would have a lot of CAMP, and we would have a lot of inhibition from myosin light chain kinase, and we would have vasodilation. The medication that inhibits phosphodiesterase, PDE3 specifically, actually it inhibits both PDE3 and 4, is myorinone. The medication is myorinone. The other thing we can do is, what if we activate adenylyl cyclase so that we can convert more AMP to CAMP? What if we do that? What if we activate adenylyl cyclase so that we can convert more AMP to CAMP? That is the function of your GS receptor. Your GS receptor. And there are medications that act on GS or activate GS receptors. By activating GS receptors, we increase adenylyl cyclase, which increases the conversion of adenosine monophosphate AMP to CAMP, and then inhibits vasoconstriction. These medications include, or chemicals, include things like epinephrine. And you may say, oh, but we saw epinephrine before, acting on GQ receptor. Do you remember this? We remember it was the alpha-1 receptor. Here, it is the beta-2 receptor. I told you before, epinephrine acts on a myriad of sympathetic receptors. It acts on alpha-1, alpha-2, beta-1, beta-2 receptors. Alpha-1 receptor causes vasoconstriction. Beta-2 receptors cause vasodilation. Remember that beta-2 receptors also cause bronchodilation. So you have to be thinking of all of these things simultaneously so you make sense of everything. The other medication is going to be prostaglandin, or chemical, really. Prostaglandins. Prostaglandins are also going to activate GS, prostacyclin. You may remember prostacyclin as PGI2. Good. That guy also activates GS. Phenoldopa. You hear the name dopam, a dopamine agonist, right? And finally, adenosine. These medications have GS effects, and they are going to activate adenylyl cyclase, increase CAMP, and inhibit myosin light chain kinase to cause vasodilation. The ultimate result of this is going to be, let's put it in this bright color, vasodilation. That's the goal. So this is one way to cause vasodilation. The other way to cause vasodilation is going to be myosin light chain phosphorylase. So myosin light chain phosphorylase for us causes vasodilation. Remember, we said it dephosphorylates myosin light chain, myosin itself, and causes vasodilation or relaxation. So if we want to get more vasodilation, perhaps we should just get more myosin light chain phosphorylase. Maybe if we want to get more vasodilation, we should get more myosin light chain phosphorylase. If we can get more of that, we will get more vasodilation, right? And the way to get more myosin light chain phosphorylase activity is to increase CGMP. If we can increase CGMP, we would get more myosin light chain phosphorylase activity. And CGMP is gotten from GTP. CAMP from AMP, CGMP from GTP, okay? GTP is converted to CGMP. Now, again, just like we did before, after this conversion occurs, CGMP will be converted back to GTP with the help of the enzyme phosphodiesterase, again, PDE5. This time it's 5, not 3. Okay, you want to remember that murinone inhibits PDE 3 and 4 actually. Okay, PDE 5. So if we can stop this PDE 5 from converting CGMP back to GTP, we will increase the amount of CGMP by a lot, and CGMP in turn will activate myosin light chain phosphorylase and cause vasodilation, right? So let's inhibit CGMP. That's the goal, right? Sorry, not CGMP. Let's inhibit PDE5. Let's inhibit PDE5. To inhibit PDE5, the medication is going to be sildenafil. The medication is sildenafil. We have a lot of them: sildenafil, tadalafil, tadalafil, whatever. All the medication in that class inhibit PDE5, and by inhibiting PDE5, they increase CGMP. By increasing CGMP, they will activate myosin light chain phosphorylase and cause more and more vasodilation. The other thing to consider is this: GTP becomes CGMP under the influence of nitric oxide. GTP becomes CGMP under the influence of nitric oxide. So, what if we can increase our nitric oxide activity, right? What if we can increase nitric oxide activity, the amount of nitric oxide we have in the body? Then we would have more dilation. Do you remember where we get nitric oxide from? We could get it from nitrates. So let's call these nitric oxide sources maybe. We could get them from nitrates. We'll talk about nitrates much later: nitroglycerin, monohydrate, bihydrate, and all of those things. We'll look at them much later. So by taking nitrates, we can provide our body with nitric oxide. We could get nitric oxide from natriuretic peptides. Natriuretic peptides. Think of your AMP, think of your BNP, right? Natriuretic peptide agonists, rather, I should say. So medications that can increase AMP and BNP, for example, will also increase your nitric oxide. Finally, we can get nitric oxide from arginine. We can get nitric oxide from arginine. Now, arginine, I think it's especially L-arginine, becomes nitric oxide or produces nitric oxide under the influence of arginase. Under the influence of arginase, okay? Arginase is activated by a lot of things, but one of them I want you to know is LPS, bacterial LPS. Bacterial LPS can activate arginase and produce a lot of nitric oxide. This is why, part of the reasons why when people get septic shock, they have widespread vasodilation and hypotension. This is one of the mechanisms or the possible mechanisms. So there you have it. These are means to cause vasodilation and means to cause vasoconstriction. There is one last thing I told you we are going to come back that we did not mention, and it's because it doesn't fall exactly into the categories the way I would like it. It is the medications calcium channel blockers. Calcium channel blockers. One way we can cause vasoconstriction or vasodilation rather is going to be to inhibit these calcium receptors. We said earlier that by inhibiting myosin light chain kinase, we cause vasodilation. And you remember we had highlighted that calcium calmodulin complex activates myosin light chain kinase and causes vasoconstriction. Now, to stop vasoconstriction, what if we can inhibit calcium? Let's stop calcium from coming into the cell. Let's stop calcium from coming into the cell. How can we do that? Let's give some calcium channel blockers. CCBs, right? Let's give some calcium channel blockers. Now we have to give the type of calcium channel blockers, and we'll talk about calcium channel blockers in the next section, that actually inhibits calcium channels in blood vessels. Those are the dihydropyridine calcium channel blockers. The dihydropyridine calcium channel blockers. So you have medications like nifedipine, amlodipine, right? What's clevidipine? They have all these prefixes. It's difficult to recall all of them. What else? We have nimodipine, and we have like nicardipine. You don't have to remember all those names. All you need to know is the ending and some specific properties of each of these medications. And that is that. We'll talk about more specifics on these hypertensive medications in the next section. Calcium channel blockers. We've already seen a lot about these medications at this point. Very important medications. There are two types of calcium channel blockers that you need to know, two classes that is, that the non-dihydropyridine and the dihydropyridine. Calcium channel blockers. Non-dihydropyridine and dihydropyridine calcium channel blockers. The non-dihydropyridine calcium channel blockers consist mainly of two medications, primarily of two medications, verapamil and diltiazem. They consist mainly of two medications, verapamil and diltiazem. The dihydropyridine calcium channel blockers consist of all the other calcium channel blockers, medications like amlodipine, what's the other one? Clevidipine. This prefix is difficult to remember. Nifedipine, nicardipine, and nimodipine. All right, so these are going to be your dihydropyridine calcium channel blockers. Right here, you already notice the difference. Your non-dihydropyridine calcium channel blockers are going to work on the heart, especially. Right? They're going to work on the heart, especially. Whereas your dihydropyridine calcium channel blockers work on the blood vessels. For the most part. They're all calcium channel blockers anyway, and they inhibit L-type calcium channel. We already saw this diagram before that showed us how calcium plays a role in muscle contraction. Calcium gets into the cell, the myocyte, for example, smooth muscle cell, and then when it gets in here, it forms this complex, calcium calmodulin complex. It forms this complex with calmodulin, and then this complex activates myosin light chain kinase. And we had said that myosin light chain kinase is going to phosphorylate myosin and result in muscle contraction. Very important that you remember this pathway. So these calcium channels, we can say that calcium channel blockers decrease muscle contraction if we are going to describe their mechanism by blocking L-type calcium channels. They decrease muscle contraction by blocking L-type calcium channels. What this means automatically is that they're going to cause vasodilation. They're going to cause vasodilation. We've already seen calcium channel blockers when we talked about antiarrhythmics. You may remember that your calcium channel blockers were your class 4 antiarrhythmic medications. So we've talked about them fairly before. And when we talked about antiarrhythmic medication, we were really talking about verapamil and diltiazem, the non-dihydropyridine calcium channel blockers. Now we look at the uses of the dihydropyridine calcium channel blockers. They are used for hypertension. These medications will be used for hypertension. They'll be used for angina, especially including metal angina. Or vasospastic angina. Do you remember what disease has similar mechanism of action as metal angina? If you think of it, I hope you're thinking of Raynaud phenomenon. Raynaud phenomenon, where you have spasm of blood vessels to the limbs, maybe to the hand, to the lower limb, whatever, resulting in changes from white to red to blue and all that. That disorder, Raynaud phenomenon, is also treated with calcium channel blockers. Do you notice a pattern here? Do you remember any other disease that has similar mechanism? I hope you're thinking about esophageal spasm. Again, we'll treat esophageal spasm with calcium channel blockers. Sometimes, if you pay attention to different pathologies that appear like they share common mechanisms or common disease, underlying disease process, you would notice that they are also treated similarly. And this is important because it helps you create associations. It helps you make connections. It means that you are actually seeing concepts and not just memorizing information, right? All right, let's talk more about calcium channel blockers. We use them for metal angina, we use them for hypertension, we use them for Raynaud phenomenon, potentially for esophageal spasm as well. Some of them are used for specific purposes. For example, we have nimodipine. Nimodipine is used for subarachnoid hemorrhage to reduce or prevent rebleeding, okay? And then we have a number of them that are used for hypertensive emergency medication like nicardipine and clevidipine. These are not the biggest points on your exam, but you should know them just in case. They are used for hypertensive emergency. Hypertensive emergency. You want to know that, right? The non-dihydropyridine calcium channel blockers, verapamil and diltiazem, we already established work on the heart. And we can put them somewhere here just to give them space. We've already talked about calcium channel blockers under certain headings before. We use them for arrhythmias. You remember they were antiarrhythmic agents, and we use them for atrial fibrillation. We use them for atrial flutter. We use them for supraventricular tachycardia prevention. So we use them to prevent supraventricular tachycardias. You want to remember that. And then we talk about side effects of these medications. The side effects of these medications. Specifically, verapamil and diltiazem tend to cause hyperprolactinemia, especially verapamil. So you want to remember this for verapamil. Verapamil causes hyperprolactinemia. Together, they can cause AV block and other calcium channel blockers. So you expect them to have something to do with constipation. Remember that hypercalcemia causes constipation, right? You expect them to cause constipation. And then we have the other calcium channel blockers, your dihydropyridine calcium channel blockers. Your dihydropyridine calcium channel blockers. These guys are going to cause edema. They'll cause flushing. They'll cause dizziness, especially if in overdose. If you cause excessive vasodilation, then fluid is going to accumulate in the periphery. There'll be less blood flowing to the brain, and so there'll be dizziness. And you have to know this. Remember all of this information about your calcium channel blockers. Remember the difference between non-dihydropyridine and dihydropyridine calcium channel blockers, and remember their side effects as well. Remember their side effects as well. I think we didn't mention gingival hyperplasia somewhere here. I almost forgot that. Remember gingival hyperplasia. I usually associate it with verapamil, but there are other associations that have been made as well. So think of that. Okay, let's go. Adenosine. Adenosine is a very short-acting medication, works for about just 15 seconds, and it's done. What do you want to remember here? You want to know that adenosine is used specifically in diagnosis and elimination of supraventricular tachycardias. Adenosine is very short-acting, about 15 seconds. It's used especially for supraventricular tachycardias, for diagnosis and extinction or elimination of supraventricular tachycardia. This mechanism of action is not usually the big deal on the exam, but you want to know that it causes potassium efflux from cells. And what's going to happen if you remember those waves we were talking about, even whether you're considering the myocardial action potential or considering the SA node, AV node action potential, whenever there's potassium efflux, we affect this repolarization area the most. And adenosine is going to cause hyperpolarization. If you're giving a medication like adenosine, you're going to cause hyperpolarization and decreased AV node conduction. You cause hyperpolarization and decreased AV node conduction. So automatically right there, you know that when you think of adenosine, you're going to cause, you decrease the slope actually. You decrease the slope of this phase of action potential. All right, that's that. The other part of adenosine that you may want to worry, I think this is the most important part, supraventricular tachycardia, diagnosis and extinction. But it has its own side effect. Adenosine tends to cause flushing. It tends to cause bronchoconstriction. That would create a sense of impending doom. It's almost the feeling people have that are going to die. Adenosine gives such a feeling. It can result in hypotension, decrease the blood pressure, and when that happens, you expect the person to be lightheaded. So there'll be lightheadedness. You expect them to feel dizzy, the same thing, basically, right? Hypotension would produce any of those effects. Then there tends to be some peripheral neural sensations. Well, how do we describe them? As tingling sensations, yes. We talk about tingling sensations in the arms. You want to know those about adenosine. We have magnesium sulfate or magnesium. Magnesium is used to manage digoxin toxicity. We also use magnesium for torsades. The point is, magnesium is going to cause bradycardia as a side effect. You want to remember, although we use magnesium for digoxin toxicity, you want to remember digifab for digoxin toxicity. There are times when they will ask you a question and they will describe something like an immunologic mechanism. An immunologic mechanism of action for this medication. So they're using a medication that works immunologically. Digoxin is like an antibody kind of medication. Digifab rather. Digifab is like an antibody type of medication. So it works via immunologic means or immunologic mechanism. And you want to bear that in mind because that is a potential question someone could ask you. All right. And that is that.